All right, good morning, everyone. Thank you for joining us for this webinar this morning titled Introduction to the Health Disparities Calculator and Utilization for Identifying QI Opportunities. I'm Bijou Hunt. I'm the director here at the Sinai Infectious Disease Center, as well as an epidemiologist in the Sinai Urban Health Institute. I'm going to be joined this morning by my colleague, Bridget Magner, the program manager for HIV and Hep C at Erie Family Health Centers. I'm not sure where everybody's tuning in from this morning. I'm in my office under a recently purchased blanket, trying to stay warm. So hopefully everybody's in a good, cozy spot for the webinar this morning. So thanks again for joining us. We're going to go ahead and get started. I want to just first review our learning objectives for this morning. So we're going to start off just defining health disparity, some background on the disparities calculator, and then our hope is that by the end you'll understand how the disparities calculator works, how to enter data into the disparities calculator, and also how to interpret findings and plan next steps accordingly. So I just want to give a little background. I'm not sure if folks on the call are participants in the CDPH Learning Collaborative. That's where I first learned about the disparities calculator, and that was through a presentation that was provided by Bridget, who is going to co-lead the next few slides, but I thought that the presentation she gave was really helpful in getting the CDPH Learning Collaborative organizations familiar with the tool. So I'm going to turn it over to Bridget here, and then I'll pick it back up in a minute. So Bridget, I think passing it to you, although, yeah.
Right. Yes, looks like it. So thank you so much, Bijou, and good morning, everyone. To start, we're going to talk a little bit about some of the terminology related to health disparities, just so that we are all on the same page. So first, we're going to talk about health inequalities, and these are a little bit different than health disparities or inequities. So a health inequality is when two groups have different health outcomes from each other. So as a couple of examples, older adults have more cancer than younger adults. This is a health inequality. One group has different outcomes than the other group, but it also makes sense. Higher age leads to higher cancer risk. A second example is professional tennis players have more arm injuries than the general population. Again, makes sense. Tennis players are using their arms more regularly, in a more vigorous way than the rest of us, and using repetitive motions over and over. Women have higher rates of breast cancer than men. So again, different outcomes between the two groups. Again, this is an expected health outcome, health difference. Another example are that Jewish persons with ancestral origins in Northern Europe have higher rates of Tay-Sachs disease. This is a genetic condition, and this group has more of the gene that leads to this disease than other populations. And as a last example, African Americans have higher rates of sickle cell disease. Again, this is another genetic condition than other racial groups. So again, they have more of the gene leading to more of the disease. So these are all inequalities where groups have different outcomes than each other. But an inequality is not the same thing as an inequity. So a health disparity, for the purposes of our conversation today, a health disparity is also known as a health inequity. So unlike the previous examples, health disparities are preventable differences, and they are experienced by socially disadvantaged racial, ethnic, and other population groups. So again, unlike the tennis elbow, where tennis players have more arm injuries than the general population, or older folks getting more cancer than younger folks. These affect groups that are socially disadvantaged, and these are preventable. They are not expected necessarily. So Again, health inequities are those health differences that adversely affect groups of people who are systematically disadvantaged based on racial or ethnic group, religion, socioeconomic status, gender, mental health, cognitive, sensory, or physical disability, sexual orientation, geographic location, or other characteristics that are historically linked to discrimination or exclusion. So this is deeper than those health differences, and these are health differences that affect those who already face more barriers, challenges, or systematic disadvantages and discrimination. So when there are fewer health disparities, there is greater health equity. A reduction in health disparities means we're moving towards greater health equity. And when we talk about greater health equity, we want to raise the health outcomes of those who are disadvantaged rather than worsen the health of those who are more advantaged. So as an example, on average, African American women have lower birth weight babies than white or Latina women. So to solve this health disparity, we're not trying to worsen the birth outcomes for white and Latina women, but trying to bring African American women's babies up to at least that of white and Latina women, if not greater than. When we talk about HIV disparities, there are a multitude of examples that we can go to. So we can see that African Americans make up about 13% of the United States population, but represent nearly half of all new HIV diagnoses. If there was not a disparity here, we would expect the proportion of new HIV diagnoses in the population to match the makeup of our population. With HIV disparities, we can see disparities across the board with viral suppression, new diagnoses, retention in care, housing status, and the list goes on and on. So why are we talking about this today? Health disparities are obviously a very important part of public health, but we cannot solve the HIV epidemic without taking a look at HIV disparities. This is seen in our national HIV/AIDS strategy, which the Obama administration created a 2010 version and then updated to our 2020 version. That one of the key components of the national HIV/AIDS strategy is to reduce HIV-related health disparities and inequities. Also, the Chicago Department of Public Health recently revamped their pillars, two of which are related to health disparities, including health equity and undoing racism. So again, we will not be able to end the epidemic without taking a look at these disparities. A little bit of background on the Disparities Calculator. This was presented at the 2016 National Ryan White Conference, and it's a tool that is designed to help Ryan White program recipients make decisions about how to improve the disparities within their own program. So the reason why I love the tool is because it is data-driven, it is not based on intuition or gut feeling. It really looks at the data and helps prioritize where you can make the most meaningful change within your own program. And I believe from here on out, Bijou is going to talk more about the tool and how to use it yourself. So I'm going to pass the ball back to Bijou.
All right, thanks, Bridget, for that great background. So I'm just going to pick right up there. So the Disparities Calculator, the tool itself is available at the link that is pasted here. There are also a ton of resources for working with the tool. So, anything that we don't cover today, if people are curious and want to learn a little bit more, there's several, I think there's maybe 5 PowerPoint presentations that accompany this tool. So there's a lot of information there if you want to take a look at that link provided here. So we're going to jump right into the tool. Just kind of getting familiar with it before we take a closer look at the tool itself. So there are 4 subpopulations that we're going to be looking at when we're working with the Disparities Calculator tool. These are MSM of color, African American and Latino women, youth, and transgender people. So first, let's just look at some disparities data on these groups. So among MSM, 2% of the U.S. population identify as MSM. However, 63% of new HIV infections are among MSM. So again, kind of echoing what Bridget pointed out earlier, we can see that there is a disproportionate impact on this population when it comes to HIV incidence. Similarly, for African American and Latino women, what we see is that 14% of the female population is Black or African American, but 68% of new infections occur among this group. While for for white women, while they make up about 62% of the female population, only 17% of new cases occurred among white women. And then for Latino women, we actually see their incidence aligning fairly closely with their population. So for disparities among youth, this group makes up about 17% of the U.S. population. However, over a quarter of new infections occur among this group. So again, we see that disproportionate impact among youth. And then for transgender people, the studies have suggested that the rate of prevalence among transgender women is anywhere between 19 and 28%. And more than half, about 56% of Black or African American transgender women are living with HIV. So again, just regrouping, these are going to be the subpopulations that we're going to be looking at when we use this tool. And then among those subpopulations, there's going to be 2 measures that we're going to be examining. The first is viral suppression, and that's going to be defined as less than 200 copies at the last HIV viral load test. For the other measure, medical visit frequency, we're going to be looking at the number of patients who had at least 1 medical visit in each 6-month period of the 24-month measurement period, and 60 days between the first in the prior 6 months and the last in the subsequent 6 months. That measure is often going to be referred to as engagement. So if you see the term engagement, that's sort of used alongside medical visit frequency. So that's engagement in care. So the question that we're trying to answer when we use the disparities calculator is there a disparity, and if so, where? So again, we're looking at these 4 subpopulations: MSM of color, African American and Latino women, youth and transgender individuals. And then we're looking at these 2 measures or outcomes for those groups, viral suppression and medical visit frequency. And we're comparing those outcomes for each of those groups to our total population, which is going to be specific to your organization, to see whether any of those groups significantly differ from the overall clinic population. So once you have the workbook downloaded, you're going to see that there are several tabs in the workbook. This is really nice. There's a lot of great documentation, and we're going to walk through what those tabs offer. So the instructions tab is going to give you descriptions of each of the tabs in the workbook, instructions for how to enter data. The Stats Basics tab is nice. It's going to provide a refresher on statistics and terminology. The Data Entry tab, this is the single place to enter data in the calculator. So what you're going to find is that all of the other tabs all of the other cells are going to be locked, and except a few cells in the Data Entry tab where you're going to be inputting data from your organization. Then you're going to find there are the Summary and Analyses tabs. The Analyses tabs we're going to talk a little bit about. There's a lot going on here, and fortunately, the way that the disparities calculator has been set up, you can mostly focus on the summaries tab, and you don't have to worry too much about what's going on in the analyses tab because all the calculations are being made for you behind the scenes as soon as you enter your organization's information into the data entry tab. So let's take a closer look at what you're going to find in the Disparities Calculator tool. So you're going to get some sample data just to demonstrate the calculations. Again, you're going to get the Stats Basic tab, which is going to have some stats refreshers, the Data Entry tab, where you're going to actually input your organization's information, and then you're going to have tabs for both viral suppression and engagement, and you're going to have analysis tabs for each of those outcomes, as well as summary tabs for each of those outcomes. In the Instructions tab, you're also going to have a walkthrough of how to use the Data Entry tab. So it's nice they have these numbered and sort of labeled for you. So what you're going to see is the first thing you're going to want to do is update your contact and agency names, the measurement period, the reporting date, and the data source. I really like that they've built this in for you. I'm not sure how many of you have an experience like mine where a lot of times I start spreadsheets, I run a bunch of data, it all makes sense to me at the time, but when I come back to it later, I don't always know, oh, what period was this data for? When did I run this data? If someone else comes along, they don't even know that I was the author. So it's nice that they've built this in, and I think it's really important for all of us to update all of the information in that first area. Here by number 2, you're going to see this is where you'd enter the number of agencies in your data set. So this is really going to be applicable to anybody who is aggregating data across sites. For the purpose of our conversation today, I'm going to assume that everybody is just working with your own organization's data and that you're not aggregating data across sites. But the nice thing with this tool is that if you are aggregating data, you can indicate there how many sites you're aggregating across. Okay, and then in spaces 3 and 4, this is what it really all boils down to, is where you're entering your numerator and denominator data for your total population, as well as your 4 subpopulations for these 2 measures, viral load and medical visit frequency. And then in number 5, there's a space for entering comments. Theoretically, although my experience has been that these cells are actually also locked, so I personally have not been able to add any comments there, but I'm not sure if the tool has been updated or if others have a different experience.
Excuse me, we have a question from Dr. Corey Bloom. She wants to know if transgender individuals include trans women, men, and also non-binary gender-expansive people.
Sure. I have not seen where the sort of the creators of the Disparities Calculator have defined what specific groups they mean to include. So my answer to that, I think, would be that it is up to the agency what makes sense for your own definition. I guess if you were, trying to compare your data to someone else's data, you would just want to be clear about how you had defined that group. Hopefully that answers the question. We can also discuss that more at the end if other people have thoughts on that as well. So also contained in the Instructions tab is this nice, there's sort of 2 analysis flows. I'm going to focus again on the individual organization analysis flow versus the group or aggregate flow at the bottom. So the first thing that you're going to need is your clean active patient list with demographics. From there, you're going to produce your overall clinic numerator and denominator for each measure, the 2 measures again being viral suppression and engagement or medical visit frequency. And then you're also going to produce the focus population numerator and denominator for each of the 2 measures. So again, the focus population are the 4 subpopulations that we've talked about. From there, you're going to enter the overall and focus population data into the data entry tab and add comments if you're able to. And then you're going to review the summary tab, send that with the analysis to your CQM, and then, this part I think gets a little sort of organization specific. So the process here, they have laid out how they sort of expect it to happen. I think that it's probably going to differ by organization just based on what your CQM, how it's set up, what it looks like. So towards the end of today's presentation, I'll talk a little bit about kind of what we did once we got our data. But again, I think that that is just sort of specific to each organization. So there's also a Staff Basic tab in the Disparities Calculator tool. There's just a few things that I want to point out here. One is under statistical terminology, number 1B, they note here that if a result is showing as undefined result, it means we should ignore the method and move on. I just want to point that out because I think, probably most people, myself included, if you see something like undefined result, you think, oh no, I've done something wrong. Do I need to go back and take another look at my data? So just note that the undefined result doesn't necessarily need to raise a red flag for anyone. Confidence intervals, some folks may know if the confidence interval contains the value 1, the result is not significant and should be ignored. But fortunately, as pointed out in number 3 here, the Disparities Calculator tool in the Summary tab, which we'll take a look at in a minute, is going to make this very easy for you, and it's going to say whether there is yes, maybe, or no disparity. So you won't have to kind of dig around to interpret the results yourself. They really kind of hit you over the head with it, which we'll see in a few slides here. So the data entry tab, again, this is the single place that you are going to be entering data. I'm going to see if I can get my laser pointer out here. So again, you're going to calculate the numerator and denominator for your total clinic population. So here in this example, it looks like their clinic population is 100 individuals. 90 of their individuals were virally suppressed, 80 were engaged in care, and then they break out their subpopulation data. So it looks like they had 5 transgender people, 40 MSM of color, 50 African American and Latino women, and 12 youth. And then their numerator data is input here for viral load and here for medical visit frequency, theoretically comments over here. So that's again, your data entry tab. And once you input your data here, all the calculations go on behind the scenes. So that's where all of the data you've put into the data entry tab is going to feed into your analyses tabs. So you're going to be able to see like your absolute disparity, for example, your odds ratios. Again, I want to really stress that if this feels overwhelming to you, don't worry. You do not have to be here in the weeds with the analyses tabs. You're going to have the nice summary tab, which we'll get to in a minute. That's going to make things very clear. One thing I do want to point out also on the analyses tab is this absolute impact and how this is working behind the scenes. So the absolute disparity multiplied by the size of the population experiencing the disparity. And really what you're going to be seeing with this absolute impact, which is again going to be included on your summary tab, is how many lives are affected by bringing the scores of one group to be equivalent to another group. So basically, if you closed the disparity between whichever of your subpopulations compared to the total population, how many lives would be affected. So again, we're going to see that in the summary tab. So here's the summary tab that I keep referring to. Again, you're going to have a separate summary tab for your viral load suppression, and then you're going to have one for your engagement or your medical visit frequency. So you want to look for those two separate tabs. And here at the top, you're going to be able to see which summary you're looking at. It's also named in the tab title, so you'll see it there as well. So looking at our example, we see that their overall viral load suppression is 90%. And then here, as I was saying, the tool makes it very easy for you to see where there is a disparity. Not only do they write, yes, disparity, they also make a red color in the cell. So you can really hone in and see exactly where your disparities are occurring. And then as we were just mentioning, we have this sort of where to focus your energy based on the impact. And those colors are reflected here in the absolute impact row. So you'll match up your disparity with where you're seeing the deepest color, and we'll talk about how to interpret these colors in the next slide. So again, determining your priorities for disparity, you're going to be using this tool. Again, it's nice because they're always going to put it here for you in your summary tab, so you don't have to sort of memorize, wait, do I like the lighter color, the darker color, which one do I focus on? It's going to be right here for you. But so using this, the purpose of using this is really just, that we have limited time and resources to focus in our activities. So we want to know which group in our assessment had the greatest number of significant results across probability methods, and also which group in our assessment had the greatest number of lives that can be improved. Now, oftentimes the most probable and the highest impact groups are not going to be the same, so a decision has to be made about whether the impact or the probability is more important. So using this graphic to the right, you can focus your energy where there is the deepest red. Okay, so they make that very clear here. They want you to focus here where you have the deepest red, and then avoid spending your energy where there is white in the graphic to the right. So again, we're going to get to see an example of some results and how to interpret them with this tool included. So now I'm going to talk about our experience at the Sinai Infectious Disease Center using this tool. So I'm going to share some of our data and then sort of how we have proceeded with our data. So just again, giving a quick look at what we're going to be completing here. We're going to do part 1, where we put in our agency information, 2, how many agencies, 3 and 4, entering the data, and 5, again, making comments. So I do want to bring this analysis flow back up for a minute. So the first step for us was to produce a clean active patient list and demographics. Then we produced the overall clinic numerator and denominator for each measure, and then the focus population numerator and denominator. So, I do want to just take a minute to acknowledge that these 3 boxes, these are very straightforward instructions. However, this in and of itself can be very challenging for organizations, particularly if you don't have, a data specialist on the team who can easily produce, even this first list, getting demographics there. I think that the ability to produce this list varies widely across organizations. And so I think it's important to acknowledge that. For our organization, we use our electronic medical record in conjunction with our RWHAP database. Some of you may have been present for a presentation I gave at the CDPH Learning Collaborative on RWHAP and how we use RWHAP to supplement our EMR. I think at some organizations, you're able to easily modify your EMR so that you can collect additional information, demographics, things that would help you know which patients fall into which subgroups. Our EMR doesn't permit that, and so that's why we use RWHAP to produce a lot of this type of data. And I'm happy to talk more about RWHAP at the end of the presentation if folks have questions about that as well. So here's what our data entry tab looks like. Again, I'm putting my name of agency, my name, Bijou Hunt. The measurement period for us was 3/1/17 to 2/28/18, which at this point sounds very outdated. But at the time in August, when we were pulling this data together, that for us was the most recent complete year of data that we had that was on the CDPH grant cycle. And we wanted to do the CDPH grant cycle just because this was a CDPH activity. And so for us, it made sense to use that measurement period. Any measurement period is fine. I just, again, want to stress that it's important to make a note of the measurement period so you know what period was being measured. And then if you're doing subsequent follow-up to see if any of your indicators have changed, you can make sure that you're using a measurement period that doesn't maybe overlap with the one you've already done. So again, getting to filling out the data entry tab. So for us, we had 311 patients during this measurement period. We had, we suppressed the cell sizes were small for transgender, so we suppressed the cell sizes there. 102 MSM of color, 109 African American and Latino women, and 21 youth. So once we put our denominators in, then we put our numerators for viral suppression. We had 83 or about 81% suppressed among MSM of color. 84 African American and Latino women were suppressed. That was about 77%. 15 of our 21 youth were suppressed. That was about 71%. And then for engagement, overall population was at 83%. MSM of color was about 89%. About 81% for African American and Latino women, and 62% for youth. So going back to something that Bridget mentioned earlier, the really nice thing about this tool is, you know, for some people, like producing these numbers, that could be enough. You might just look and say, oh, well, I can see one's lower than the other, so I'm going to focus on that. Or this one isn't that low, so it's probably not that big of a difference, so I won't focus on that. The nice thing with this tool is that you can really get a clear answer about where there are statistically significant differences and where you could focus to get the most impact. So to that end, here is the summary tab for viral suppression using our data. So our overall viral suppression for our total clinic population was about 80%. And what we see here is that we don't have any red cells. We don't have anybody yelling, yes, there's a disparity here. We have a maybe disparity here, but then we have a white cell here, which again, you'll recall the sort of lighter that we get, especially into the white, those are areas we're going to avoid. On the flip side, our darkest area is where we want to focus. That would be this cell. However, there's no disparity here. So for us, viral suppression did not end up being an area of focus.
This is Estella again. We have another question from Dr. Corrine Bloom. She wants to know, when you refer to women, are you specifying cisgender women, or does this include transgender women as well?
So let me think about that. I believe, you know, because I came across a question when I was reviewing these materials where someone said, well, if you have youth, but they're also MSM of color, do you count them in both categories? I think for our purposes, we would count transgender if they were African American and Latina, but also transgender. I think we would count them only in the transgender category and not in the African American and Latina women category. I think that one is a little tricky, and I think it's also kind of going to depend on your cell counts. I don't know that I have a good answer for that. Again, when I was reviewing the materials, they seemed to be implying that you would count youth MSM of color in both categories. So I mean, I guess to this question, I would say you would count it in both, but I haven't seen a lot of clear guidance around that, and I'm certainly not the expert. So I'm sorry, I just don't think I have a great answer for that question.
Bridget, if you don't mind, Bijou. So yeah, those population categories are what were recommended by the National Ryan White Conference and the Clinical Quality Group. However, you can choose your own populations. The tool has some locked cells, so it's not too easy to, actually change the title of the columns to match the populations that you would like to map out. But you can look at your own data and do it either way. You can see if putting those folks in just the transgender persons category, how that looks compared to adding them in with the African American and Latina women. What we did at Erie was only have them in the transgender persons category, but you can really manipulate the data and look at your own populations. This is supposed to be a tool that can be adapted to your agency and the populations that you see. And so you can kind of try it both ways, see how it looks. And you can also add in different categories. If you serve folks, you can look at low income or housing insecure or any categories that you would like.
Thanks, Bridget. That's a great answer. I appreciate it. Okay, so looking at our summary data for medical visit frequency, here what we see is for our overall clinic population, we're around 83%. And then some of you may have already had a little flag go off a few slides ago when you saw our 62% engagement among the youth population. And if your flag went off, now here it is being sort of verified by the statistics. So there is a disparity in this group. And what we see here is that while we're not at the deepest red, we are still in the red zone. So this is the area that we decided to focus on. I do want to just note here we see another case where we have a dark cell, so this would be an area of high impact. However, we didn't have a disparity here because this group was up at about 89% for engagement. So there's no disparity, so we wouldn't focus our effort here. But this seems like a great place to focus our energy, and so this is what we decided we would focus on based on the data from this tool. So once we had finished entering our data, well, first generating our data, entering our data, analyzing the results, then the question was sort of, now what do we do? So again, as I stated earlier, this can kind of depend based on your organization and how CQM works there. What we did is we had, based on our results, we had our mental health and psychosocial services providers, Jackie Frankie and Teresa Gonzalez. They led our team through the results and a discussion of ideas for improving these outcomes. So they're both part of our QM process. And so we wanted to take this information, share it at one of our all-staff meetings, and get ideas about what we could do. So here were some of the ideas that we came up with for improving medical visit frequency among the youth population. I'll just breeze through these. So texting or using social media, giving more notice for appointment reminders, providing intense navigation for the youth population, maybe providing more targeted education about adherence to appointments. One idea that folks liked was maybe providing drinks or snacks in the clinic fridge or providing a brown bag of non-perishables so that when youth pick up medications or attend medical appointments, we'd be able to provide them with a small bag of food, providing targeted U equals U education, importantly, continuing contact between appointments so we don't lose contact if they change numbers. Providing targeted messaging from our providers. We talked about just generally trying to make things more fun. And then using our Friday clinic as a backup plan if an appointment is missed during the week. So those were some of the ideas that were generated in our brainstorming session. I did want to share a few other ideas because the CDPH Learning Collaborative, which again is where the Disparities Calculator was first introduced to our organization and a lot of others, we had our last quarterly meeting last week, and there were some really great ideas shared there. So I wanted to highlight a few. Melissa Bourdonnais from AIDS Healthcare Foundation shared one thing they do, this 104 report to address attention. So providers get a list of patients who haven't had a visit in the last 104 days, and then the providers call those patients individually to follow up and try to schedule them. Erin Hankey from Heartland Alliance Health shared their out-of-touch agreement. This is a form where the patient provides alternative contacts and frequent locations to facilitate locating them if needed. So I thought that could be helpful for folks who are working with transient populations. John Pariseau from Michael Reese shared their viral load and U=U survey and education. So what they did was assess patients' knowledge of and provided education about viral load and U=U. That one I thought was really, really helpful. He found that I think he said none of his patients had heard of U=U. Few could really explain what the viral load was. And so that provided an opportunity for him to provide some education around those things. And then finally, Karen Lee from University of Chicago talked about tracking, tailoring, and mentoring. So they implemented some formal tracking systems. They talked about the importance of providing tailored messaging based on the subpopulation that you're focusing on. And then also leveraging peers as mentors. So leveraging those individuals who are succeeding and having them mentor individuals who are experiencing some challenges. So kind of teaming up those two groups. So those were some other helpful initiatives that other organizations had shared. And if we have some time at the end here, it would be great if other folks want to share ideas that they have. So for us, our next steps are going to be to implement one or more of these ideas. We're going to monitor the data at 3 and 6 months post-implementation. And then importantly, we're going to continue to examine outcomes for both measures for all subpopulations. So this, I think, is a really important point because, as I'm sure you are all aware, these outcomes change over time. So the subpopulation that we identified during this particular measurement period, may not be the same subpopulation that is struggling in our next measurement period. Or, for us, viral suppression did not produce any significant disparities for this measurement period, but perhaps if we look at data for another period, we will see some differences. So it's really important that we continue to use this tool to examine this type of data. So that concludes the presentation. I would love to open it up to questions and comments from folks about the presentation or other ideas that you might have about sort of how to react to the tool. So thanks, everyone. And Estella, are you going to facilitate Q&A?
Yes. So if you raise your hand, I'll unmute you so you can go ahead and ask your question, or you can ask your question in the chat box, either way. Any questions, you could raise your hand to ask a question, and I'll go ahead and unmute you.
Well, I guess Bridget and I must have just done a very thorough job with the disparities calculator. If anybody has questions, please don't hesitate. And also, again, if you have other thoughts about sort of how to react to this type of data, I'd love to hear thoughts on any initiatives that you think would be interesting or that maybe you've tried at your own organization.
Okay, I think Donna has a question. So Donna Hazelman, Donna, I'm going to unmute you so you can go ahead and ask your question. Go ahead.
Actually, it wasn't a question. I just typed in there. I just wanted to thank you for sharing this information because I think it'll come in handy with the data and the CQM that we do here at Positive Health Solutions.
Awesome. Thank you.
Thank you.
Dr. Bloom, did you have any questions or anything to add? You're unmuted, Dr. Bloom.
Thank you. I appreciate that I received the answers during the presentation. Sorry for interrupting you all.
Oh, no problem. Thank you for asking.
Did you have any other questions or thoughts or ideas? Okay. Is there anyone else that has any other questions? We would love to go ahead and field your questions. Okay, well, if not, then just go ahead. This concludes the webinar, and I'll be sharing, again, the webinar slides, the recording link to the webinar, and any questions that you may have, you could always ask one of our speakers. I'll go ahead and include their contact information as well. If there's anything else, otherwise, I believe we're done.
Okay, thanks, everyone. Stay warm.
Thank you so much.